this up a little bit. All right, so to start off with, there are 3 items of good news. I don't have any rules for this demo. I don't have any slides for this demo, and we will be finished before 3 p.m. So good news to start off with. As Dr. Paul said, I'm Alissa Willis. I'm a multiple sclerosis specialist and chair of the neurology department here at UMMC. You'll see me again next year as you rotate through clinics and also as you rotate through the general neurology service in the hospital. This is Dr. Kelsey Carr. She's a 3rd-year resident. Neurology residency is 4 years, so she's actually one of our senior residents. Both of us went to medical school here at UMMC, so we were not in these seats because this school, well, you were. Well, I'm much older. I was in the first medical school, so I was not in these seats. She was, but we definitely remember what it's like to be going into the 2nd-year course. And the neuro exam is one of the most intimidating things, or kind of mystical things. And so we're going to try to take the next hour, give or take a few, and demystify the neuro exam. We cannot show you every single neuro exam technique. It takes years to learn. Some of the variances of the neuro exam related to specific localization or conditions. But what we'll take you through is a basic neuro exam and essentially a correlation between what you learned in neuroanatomy in the 1st year and then what we look for on exam. So the neuro exam serves many purposes. One of the main purposes is to test the hypothesis that you generated in hearing a patient's story. So when I'm hearing a patient's story, I'm already thinking about where could the lesion be and forming a differential diagnosis before I even touch the patient. And I adjust my neuro exam based on what I think the answer may be. 90% of the time, with the history and with the physical exam, we can get to a diagnosis. We have lots and lots of fancy tests now. We can do MRIs, we can do biomarker tests, we can do PET scans, we can do fancy EEGs, looking at brainwave recordings. So we have lots of fancy tests that we can do, but most of the time, all we need them for is to confirm our hypothesis. So the neuro exam actually begins with the interview. You can tell a lot about the patient just from the interview, and again, you begin to formulate a hypothesis. So we're going to get down to the actual exam part, and if you begin to look like you're falling asleep or not paying attention, I'll ask questions not to pimp you, but to give Dr. Carr a chance to throw some blue squishy brains into the audience. So we'll get started by talking about the basics of the exam. The neuro exam starts with not just an examination of the nerves, but a general physical exam. So all neurologists still use one of these things. I didn't hang it up after I finished medical school and intern year. A stethoscope and ability to do a good general physical exam, sometimes it helps us understand what diagnosis the patient has and what contributed to a patient having that condition. For example, using a stethoscope, listening to carotid arteries, I can pick up a carotid bruit and I know what the patient's risk factors for having an ischemic stroke were. Another example is if I look at a patient's skin and they've got a shawl-like rash and they have a rash on their knuckles and they're coming to see me because they have muscle pain and weakness, I know right away that I'm looking for a condition like dermatomyositis. So being able to do a general physical exam is a really important component of the overall neuro exam. The first part of the neuro exam, and I put an outline there on the board for you to follow along with this. The first component of the neuro exam is mental status. And this you don't necessarily have to do a mini mental status exam to find out. You can tell a lot from just your interactions with the patient from walking into the room and from taking their history. So I'll use Dr. Paul as an example because I pick on him every year. You can tell Dr. Paul, he's awake. He seems to be alert to me. We didn't ask him orientation questions, but he showed up here on the right day at the right time, presented the right material, so we'll say that he's fully oriented. He's awake, alert, and oriented times 3. Speech and language are an important part of assessment of mental status. Dr. Paul's speech is fluent. Someone who has a frontal lobe lesion, like a stroke, they will have disfluent speech, or they'll have trouble getting their words out. But Dr. Paul's speech is fluent. He showed you a pen and he named it appropriately, so his naming is intact. We didn't check his repetition. That would be another part of assessment of language. His comprehension seems to be intact for me, although we didn't ask him to follow specific commands. So that's what I mean by assessing mental status first. If we have specific concerns about cognitive function or higher cortical functions, we may add additional tests to that. But generally, the mental status part of the exam is very quick. What else do you add to your general mental status exam?
So yeah, it's basically when you walk in, it's like the first thing: are they awake? Are they asleep? If they're attentive or they're inattentive, like if they're kind of like delirious, like they're not really paying attention to you, or if they're able to pay attention to you well. And then sometimes you can do quick memory things like recall. I'll tell them like 3 words, and then later I'll ask what those 3 words are, instead of doing like a full memory assessment. And then if they're able to give like me the actual history or not, like are they able to answer questions, or they don't remember anything, things like that.
All right. So we'll move on to the other portions of the neuro exam, and the order that you do this is very individualized. And as you're learning, you may experiment with different orders of doing the neuro exam. That's completely normal. And as you meet different faculty members and different residents, they may have a different order, and it's because that works for them. It doesn't matter what order you do the neuro exam in, as long as you cover all components of the neuro exam, and you do it the same way every time. That way you make sure that you don't miss anything. So I usually start with the cranial nerve exam, and we'll go through all the cranial nerves, although we don't test all of them in practice. So starting with cranial nerve 1. So this is something that we don't frequently test in practice, but I can tell you how to test it. Don't worry, I'm not going to make you spell anything. So I gave the answer away. Cranial nerve 1 is the olfactory nerve. And so you can test it, and this is important in people who have neurodegenerative conditions. And in the last few years, it's important in the setting of COVID, because anosmia is a common symptom associated with COVID. Early loss of smell is also associated with Parkinson's disease and Alzheimer's disease. So testing the sense of smell can sometimes be important, but it's not part of a routine exam. So to test this, what you would do is you would give a patient at least 2 samples of non-volatile stimulus. So I have a little test tube, and yes, this is probably about 10 years old, a little test tube that's filled with coffee, because most people will recognize the smell of coffee. And so you want to make sure that whatever stimulus you have, you're covering it with your hands so that they're not visual cues to the patient. And then you just have them smell. And they should be able to tell you what the smell is. Another common stimulus that's easy to carry around is cherry chapstick. You don't want to use mints or anything that is volatile, because that actually activates a different cranial nerve. So cherry chapstick is a smell that is universally recognized, and so that's another stimulus that you can give to test someone's sense of smell. All right, cranial nerve 2 is the next. So what's cranial nerve 2? Who remembers? Optic nerve. You want to throw a blue brain? I promised them that you would launch them into the audience. All right, so the optic nerve we can test in many different ways. So we want to know visual acuity associated with optic nerve function. We want to know about pupillary response, and we want to directly visualize the nerve. Sometimes we'll add color vision test, not always. We always check visual fields, and we can do a very quick visual field test at the bedside, which is what I'm going to show you with Dr. Carr. So you cover up one eye, it doesn't matter which one, and I want you to look right here at my nose. We want to test different fields of her vision. I don't want her to saccade away, so it's really important that she looks straight ahead. How many fingers do you see?
2, 5, 1, 5.
Okay. It takes some practice to figure out where the normal blind spot is, and practicing on yourself can be helpful. If I held my arm way out here, you're wrong, it's 5. So this is too far out. This is past someone's normal peripheral field. So it takes a little bit of time getting used to the distance and how far you can hold your arm out comfortably for the patient. But you want to test all 4 visual fields in each eye, and you test each eye separately. So let's check the other eye, and look here at my nose. How many fingers do you see?
5, 1, 2.
Okay. The reason that you can put your hand down. The reason that I just use 1, 2, and 5 is that it's very hard for patients to tell the difference between 4 and 5, 2, and 3. So 1, 2, 5 keeps it simple. I mean, I want to assess their visual fields just crudely, and this is not a trick question for them. So to make it as easy as possible to quickly screen visual fields. There are formal ways to test it, but we don't do that at the bedside. So that's visual field testing for cranial nerve 2. Another component that I talked about was visual acuity. There are several different ways to test it. The most common way at the bedside is using a little card that we carry in our pockets. So when you're looking at buying equipment or buying a card or borrowing one or using something that is on a spiral bound book that some people may carry around, it's really important to look at the bottom of the card to figure out what kind of card it is and whether it's a near card or a distance card. This particular card is a near card. It recommends that it's held 14 inches in front of the face. The card that's on the back of the Maxwell, the little spiral bound book, that's a distance chart. So it's meant to be held at least 6 feet away instead of near. So very important to know which kind of card you're carrying. So this is a near card, and you want to check each eye individually, and you want to do it with the best corrected vision. So if the patient wears glasses or contact lenses, you want to check it with glasses or contact lenses. Cover up one eye for me, Dr. Carr, and hold this card like you're going to read a book.
Okay.
What's the smallest line of letters of numbers that you can make out over here?
428739.
Good. Switch hands and eyes. Can you read that same line to me?
Yeah, 428739.
And for people who come up with the numbers that quick, I usually make them read it to me backwards just to make sure that they have it memorized. Perfect. So that's 20/20 vision for Dr. Carr. I always save the fundoscopic exam for the last, so I'm not going to show you that right now. The reason I do that is it's a little bit uncomfortable for the patient, and it means that we got to turn the lights off in the room. So I always save that to the very end. What I'll show you is actually a combination of cranial nerve 2 and 3. The afferent limb of the pupillary reflex is cranial nerve 2. What's the efferent limb? What nerve mediates that? I think I heard it from somebody. Oculomotor, so cranial nerve 3. All right, let's send another brain out there. All right, so the equipment that you need for checking pupils is a pen light. Please do not use the flashlight on your iPhone. That's just nasty. So use a pen light, and it needs to be a bright pen light. You don't have to spend a lot of money. This one came from Home Depot, so it's just an LED pen light. And you want the patient to look straight ahead. I don't want Dr. Carr to look at me, because if she looks at me this close, her pupils are going to get small, right? She's going to converge, so I'm not going to truly be able to assess pupillary response. The chair who did this demo when I was a medical student used to say, look at that Cadillac down the road. Most people wouldn't know what that means now, but look at that Cadillac down the road, Dr. Carr. All right? And so when I'm shining the light in her eyes and looking at her pupils, I'm looking at the alignment where my light falls. So if the alignment of the eyes is normal, the light should fall right in the center of the pupil. I'm looking at the shape of the pupil. Her pupils are round. Someone who's had cataract surgery might have an elliptical shaped pupil or some type of trauma to their eye. I'm looking to see what color is it. Is it black or is it white? I mean, someone who has white over their pupil has cataracts or glaucoma, or they have some type of ophthalmic problem. You can also see other things in looking at the eyes that give you a clue to the patient's other medical conditions. If she had a blue ring around the outside of her eye, then that's called arcus senilis, and we might be thinking, okay, it's time to check your cholesterol, Dr. Carr. She does not have arcus senilis. Her pupils are round, and the measurement of her pupils is about 4 millimeters. So when I shine the light in her eyes, I see in this eye both pupils go down. I'm going to swing the flashlight over, both pupils remain the same size. So if one pupil got big, if I shine the light in this side and both pupils went down, but shine the light in this eye and that pupil got big, that's called an afferent pupillary defect or a Marcus gum pupil. That tells me that she's got an optic nerve problem. All right?
And a bunch of pens have like the pupil sizes on them, and you can look at that if you don't know. You just look at that.
And there are ways that we can measure the pupil. It's not so important to be exact. It's more important to know, are they the same size? Are they unusually large? So someone who has very dilated eyes, we think about, have
Drugs.
Are they on drugs? Have they been given certain medications? In the case of someone who has an intracranial lesion, we might see a blown pupil in the setting of uncal herniation. So it's just important to know the size in general. You don't have to be specific about the number of millimeters. So cranial nerves 3, the rest of cranial nerve 3, 4, and 6 are usually tested together because these muscles or these nerves all innervate muscles that move the eyes. So the way that we do this is we're going to hold a hand out here at a comfort level that doesn't get her to converge. So if I have her look too close and move her eyes, she's converged and trying to move her eyes at the same time, which is uncomfortable for the patient. So hold your hand, usually it's about 3 feet back. And what I want you to do, Dr. Carr, is just follow my finger with your eyes. Don't move your head. Look all the way over here. And the movements are slow in a pattern that almost makes an H. So the reason I move my finger slowly is because I'm looking for pursuit eye movements. I don't want to see whether her saccades are abnormal with this test. There's a different way that we assess that. We're looking for smooth pursuit when we do that H diagram. All right, now cranial nerve 5. So cranial nerve 5 has a couple of components. This is a very special cranial nerve. It has both sensory and motor components, unlike the ones that we just talked about. So what muscles are innervated by cranial nerve 5? Do you remember?
Mastication.
Yeah, mastication, pterygoids, and so we can test that. We don't always test that on exam. But the way that you would do it is you have someone bite down and open, bite down, and you're feeling those muscles activate, and you're feeling for the symmetry. You can also have someone, if you're concerned about the function of the pterygoids, have them open your mouth and move your chin this way. There you go. And this way. Her pterygoid function is completely normal. The other function of cranial nerve 5 is sensory. And so we do just quick bedside testing for sensory. If someone doesn't have a complaint, we don't have to get out a safety pin and map out sensory deficits in the face. So it's a very quick, crude touch test. And we're going to look at all 3 distributions of cranial nerve 5. So do you feel this the same on both sides of your face?
Yes.
And here?
Yes.
And here?
Yes.
Remember, the angle of the jaw is not cranial nerve 5, so that's a part of a cervical dermatome. So you make sure that you're staying away from the angle of the jaw there. All right, we've already tested cranial nerve 6. That means that we're on to cranial nerve 7, which is what? Facial nerve. Okay, so you want to make sure that you check both upper and lower parts of the face. This helps us localize a lesion. When someone has a facial droop, if it's both the upper and the lower face, it localizes to a different part of the brain than if someone just has lower face weakness. So I want you to close your eyes tightly like you have soap in them. Okay, you can open your eyes. It's very important that someone you want to see them bury their eyelashes. This is very important. Someone who has facial weakness due to myasthenia gravis may be able to close their eyes, but they can't close it tightly. So if you don't ask them to close their lids tightly and bury their eyelashes, you may miss subtle facial weakness. So closing the eyes tightly is important, and then raise your eyebrows, okay? So Dr. Carr's upper part of cranial nerve 7 is normal. Let's see a big smile, show me your teeth, okay? And puff your cheeks out, okay? And you can relax. So her cranial nerve 7 is intact. And then 8, how do we test cranial nerve 8?
You can do this. I mean, you can see if they hear you when you're talking to them first, but you can do finger rub or finger flick,
Yep.
Things like that, and see if it's different on each side.
So most commonly what we do at the bedside and what we would expect you to do if you were in clinic with us is just some type of test like a finger rub. Can you hear this?
Mm-hmm.
And this?
Mm-hmm.
Okay. You may start off here and have it move in. There are lots of different ways to check finger rub. We don't expect you to check Weber and Renee. So you may read about those, you may remember from last year learning about those tests. That requires a special tuning fork. And it doesn't have as much clinical utility as you may think. So I don't expect you, when you come work with us in neurology, to do a Weber and Renee test for cranial nerve 8. 9 and 10 are usually checked together. And we do a very abbreviated exam at the bedside. So 9 and 10, if there's dysfunction, you'll pick it up with a speech. You may have a palatal speech pattern. You may have other forms of dysarthria. At the bedside, just open your mouth wide and say, ah. And what I'm looking at is I'm looking at elevation of her palate. I'm not really looking at whether the uvula is in the midline or not. Some people are just a little bit different and their uvula leans to one side or the other. I'm looking at actually the elevation of the palate. You could check a gag reflex, but that's cruel and unusual for both the patient and for the examiner. I don't like it when people vomit on me, and so I usually don't check a gag reflex unless someone is intubated. If they're in the ICU, that's when checking a gag or a cough reflex may be helpful. All right, cranial nerve 11. We're going to check sternocleidomastoids and trapezius. All right, Dr. Carr, turn your head this way. Okay, and you want to make sure that not only do you give them some resistance, but you can see the sternocleidomastoid contract. Sometimes you may actually have to put your hand there and feel it if you can't actually see it contract. Turn your head the other way. Okay. Now shrug your shoulders up and keep them up there. Don't let me push them down. Okay. Now cranial nerve 12 is the hypoglossal nerve, so this nerve helps move the tongue. The way that we test this is open your mouth, stick out your tongue. Okay, and I'm looking to see if there's any atrophy or fasciculations. If someone has an old cranial nerve 12 injury, we'll see part of their tongue atrophied, and you may see it fasciculate. If someone has a motor neuron disease like ALS or Lou Gehrig's disease, when they do that, we'll see their tongue fasciculate or writhe around. She does not have any tongue atrophy or fasciculations. Okay, open your mouth wide, stick out your tongue, and move it that way, and move it the other way. So you want to see not just tongue protrusion, but full movement of the tongue. So now we've covered all of the cranial nerves. It goes a little bit faster from here. The next part of the exam that I usually check is the motor exam, and it has a few different components. So bulk is important, muscle bulk, and it can be just a general assessment of muscle bulk, or it can be more specific. I carry a measuring tape in my bag, so if I'm not really sure if someone has atrophy on one side or the other, we can actually measure it. But a general assessment of muscle bulk would be the first step. Evaluation of tone is important because it helps us localize to an upper motor neuron process or a lower motor neuron process. And then looking at power or strength is important. So Dr. Carr appears to have normal muscle bulk. We're going to check tone, and I'm going to show you, just for the purposes of the recording, just tone in the upper extremities, but in practice we would test all four. So I want you to go as loose as you can go, and just let me move your arm around. So what I'm doing is I'm moving across two joints at the same time, and I'm changing the speed. So it's really important to know, do you get resistance throughout the full range of motion if you're getting resistance? And if you do, if you're getting resistance, is it the same with all speeds of movement? What I mean by that, rigidity, which is actually usually comes from a basal ganglia problem, rigidity gives you the same resistance no matter how fast or slow you move. On the other hand, spasticity, which is due to an upper motor neuron lesion, that fluctuates. If you go slow, it's easier to move the limb. If you go fast, you encounter more resistance. So the assessment of tone is really important. I do this before the strength exam because when you have someone activate their muscles to maximum contraction, you can actually change their tone, and I want to know what the baseline tone is. Okay, your tone is completely normal. Next, we're going to do the motor exam, and I always start with the upper extremities. Again, depending on what the patient's problem is, what their symptoms are, and what you're hypothesizing, you may add more muscles to your exam to check. But a screening exam just looks at the large muscle groups. So we start with the arm abductors. Don't let me push your arms down. And how hard am I pushing, Dr. Carr? Pretty hard, okay? You don't want to take it easy on someone. We grade muscle strength on a scale of 0 to 5. So 0 means that there's no activation of the muscle. You can't see it, you can't feel it. 5 means full strength against resistance. 4 means that they have strength against resistance, but it's not full. 3 is just anti-gravity. 2 is there's some movement, but not against gravity. And then 1 means that you can see a flicker, a contraction, but they're not really able to have any significant functional movement there. So we look at the arm abductors. Hers are 5 out of 5. It's best for these big muscle groups. If you can test them together, it helps you determine whether they're the same on both sides or not. Next, we'll look at biceps, and then we'll look at triceps. I want you to make a muscle like this. Don't let me pull it down. And if you can, if you're strong enough to test both sides at the same time, you can, or you can go back and forth like that, comparing the right to the left side. For triceps, I want you to push me away. Good. Push me away here. Good. Now we're going to look at wrist extensors. Bring your wrist back like you're riding a motorcycle. Don't let me push it down. Okay. Spread your fingers wide. Don't let me push them together. Okay. So that is a screening motor exam of the upper extremities. You do not have to check every single muscle, but those are the big muscle groups. We do the same thing in the lower extremities, check large muscle groups. We want to look at hip flexors. We want to look at knee extensors, knee flexors, ankle flexors, and ankle extensors. All right, so I want you to raise this leg straight up. Don't let me push it down. Same thing here. And again, we're comparing right to left. Sometimes it can appear that someone is weak on one side if you don't test the other side. I mean, if you just check the right side because you're focused on their complaint of right leg weakness, you may actually miss weakness on the opposite side that changes your localization. Kick this leg out and pull it back in. Good. Kick this leg out and pull it back in. Push down and bring your foot up. Push down and bring your foot up. Good. So Dr. Carr has 5 out of 5 power in all muscle groups. The next thing that I usually do is check coordination. Although some people will move on to the sensor exam or reflex exam next, it doesn't matter what you do as long as you do it in the same order. So for the sensory exam, we need to check 1 modality from each major pathway. So 1 posterior column modality at least, and 1 modality from the anterolateral system. So posterior column is what? You remember? I heard proprioception, and then there's one more thing. Vibratory sense, perfect. So you need to check at least vibration or proprioception, so 1 posterior column modality. And we'll do that next. I'll show you both. I'll show you the option for vibration, and I'll also show you how to check proprioception. So for vibration, the right tuning fork is a 128 hertz tuning fork. So at the bookstore or on Amazon, you'll see several different options. The right one for testing vibratory sense is the 128 hertz. So if you're going to get one, this is the one to get. And what you're going to do is you're going to start off by checking vibratory sensation distally, so at the most distal point that you can test. And we're going to look at her distal interphalangeal joints here. You always want to make sure that you're putting the tuning fork on bone. Do you feel a buzz, like a bumblebee buzzing? Okay, tell me when it stops. So remember, it's still going, you're right. She should be able to feel it as long as I can, assuming that I don't have any neuropathy, and she doesn't have any neuropathy, it should be the same.
It's barely there.
Yep, you're right. So in someone who has neuropathy, they may be able to feel the initial vibration, but then they feel it stop much faster. And so you would continue moving up their arm to finding a place where their vibration sense is normal to identify how severe their neuropathy is. That's how we check vibration. We can do the fingers, we can do the toes the same way. We always check arms and legs, and we always check right side and left side. If we were going to check position sense, there are a couple of different ways to do that. For large joint position sense, what you would have someone do is hold your arms out straight in front of you, close your eyes. I want you to take this finger and touch your nose. And with this finger, touch your nose. Okay? So Dr. Carr's large joint position sense in her arms is intact. The way that we look for small joint position sense is we're going to take the distal interphalangeal joint, but this time I'm going to put one finger in front of it and one finger behind it. Close your eyes, and I want you to tell me which way I'm moving your finger.
Down. Up. Down.
And I know those of you in the back can't see this, but I'm not moving her finger very much. So if someone has normal small joint proprioception, they should be able to detect very, very small movements and get it correct at least 3 out of 3 times. We can do the same thing in the
big
toes.
toe, yeah.
Mm-hmm. Yep. So that's vibration and proprioception. For the anterolateral system, the thing that we check most commonly is pain. That sounds cruel, but it's the easiest. It's much easier to check pain than it is to check temperature. So you can sometimes, if you're in the right setting, you can use a cold tuning fork to check temperature sensation, but it's much easier to assess pain. And the most common way and most hygienic way of doing this is probably to take a safety pin, an unused safety pin. It's 1 pin for each person, and then you throw it away. Don't use, if you have a reflex hammer that has a spike at the end of it or it has a little brush inside of it, don't use that. We can't clean those things. We can't sterilize them. So we don't want to be spreading things from patient to patient. So a single-use safety pin is what you do.
You'll see us have a bunch of those on our ID badges when we're walking around.
I know if they didn't have neurology on the coat, that's the way to identify the neurology residents. So we can check by dermatomes. We can look for a sensory level on the back. And what I always tell patients when I pull this out, their eyes get really big. I let them know I'm not going to stick this pin in you. I'm just going to touch it to your skin. So someone should be able to feel a light touch. Does this feel sharp to you?
Yes.
And you want to ask them that question, does it feel sharp? Not just, do you feel this? Because they may feel it and feel it as something dull. If their pain sensation is normal, they should feel it as sharp. Okay? So next, we'll check coordination. So there are several components of that, and when we're concerned about coordination abnormalities, we're trying to sort out, is there a sensory deficit or is there a cerebellar deficit? So you saw Dr. Carr earlier look at large joint proprioception. Back to that same position, with her eyes open, I want you to take this finger, touch your nose, and then touch my finger. Now go back and forth. Can you mimic someone who has a cerebellar lesion? One more time. Okay. Good. You gave 2 good examples of what we may see. You may see dysmetria, or you may see a tremor, particularly as they approach a target. That's what we're looking for with that test. Another test to do to look at coordination in the upper extremities is rapid alternating movements. So I want you to take your hand, flip it over as fast as you can, and they should be able to go really fast and be accurate. What's it called if someone is doing this? It's not asterixis. That's dysdiadochokinesia. You want to throw another brain?
Yeah. There's someone way back there. Ready? Okay.
So dysdiadochokinesia would be another cerebellar localizing sign. You can check rapid alternating movements in the feet. You would do that by having someone tap their foot, and to tap each foot separately. You can also look for ataxia in the legs. And so to do this, you have someone take the heel of one foot, put it on your knee, and run it straight down your leg. Now back up. Can you mimic someone who has ataxia? Yeah. I know I didn't warn you, you're going to have to act for this.
They'll either overshoot it or they'll kind of like wobble when they're going down.
So normal heel, knee, shin is someone can move in down in a straight line, and they can do it without looking at their leg. So that's coordination. The other parts of the coordination exam actually come up when we're checking gait. So next we'll move on to reflexes. I think the reflex exam is the bane of every third-year medical student's existence, at least as they're getting started, because it takes a lot of practice and it takes getting the position right to be able to get the reflexes correct. So we grade reflexes on a scale of 0, meaning no reflexes at all. And usually we have to have electrical tests to back that up to say that someone has no reflexes. 1+ would be diminished, 2+ would be normal, 3+ would be very brisk or hyperreflexic, 4+ means that they have clonus. All right, so we're going to find out if Dr. Carr has any of those things.
I think I have brisk ones.
In the upper extremities, I hope so. In the upper extremities, we're going to check biceps, triceps, and brachioradialis. In the lower extremities, we check knee jerk, ankle jerk, and then we look for a plantar flexor response. Also, it's commonly called a Babinski, but that's not the term that most neurologists would use for that. So in order to check a biceps reflex, the positioning is very important. Dr. Carr is already assuming the position, so she's supporting her arm there, relaxing the arm. You want to make sure that the patient is relaxed. You can localize the tendon, the biceps tendon, by taking your fingers, and if you tap your fingers, you should be able to get, and you've got spread into the brachioradialis. So you'll see flexion of the biceps here, but she's also got spread into the brachioradialis. So she does have hyperreflexia there. So in localizing the right place for the reflexes, use your fingers, and then the weight of the reflex hammer, and get a good reflex hammer, not one of those things that's a triangle. Get one that looks like this, or you can get a queen square hammer, which actually has a circle at the end of it. The hammer makes a lot of difference in whether you can get the reflexes or not. For triceps, it's very, very important to get the positioning right. So you want the patient hanging their arm as much as possible, and this is where it's really important to use your finger to localize the tendon. You don't want to go hacking away at the patient's elbow. And so I'm using my finger here to locate her triceps tendon. And it's as easy as that. For brachioradialis, it's pretty easy to find. So your brachioradialis muscle runs here. And you can really put your finger anywhere on the course of the brachioradialis muscle in order to get the reflex. We can look for an abnormal reflex called a Hoffman. So if the Hoffman is present, it suggests that there may be an upper motor neuron lesion in the cervical cord or higher. And so to do this, you have the patient relax, you extend their wrist, and you flick one of their fingers. And what you're looking for is you're looking to see if their thumb flexes in. Hers doesn't. In the lower extremities, very important to do positioning. It's hard when someone is sitting in a chair and their feet are on the floor to consistently get the reflexes. It's okay, we'll do the best we
If you
can.
get them to pop their foot up like this, it does the best though. I've learned that.
So normally we would have someone in a hospital bed, or they'd be sitting on an exam table. So having the limb supported and rest and relaxed is the key. And so you're going to want to hit the patellar tendon here. And you do have pretty brisk reflexes.
Yeah.
For the ankle jerk, it's the same thing. It's very much about positioning. So you also want to put just a little bit of stretch on the tendon, and you'll hit the tendon here just above the ankle. I promised Dr. Carr she would not take her shoes off, so we're not going to do that. But you would take the other end of your reflex hammer, and you would scrape the bottom of the foot, starting on the lateral side, and then come across the forefoot with pretty good pressure. It shouldn't be enough pressure to hurt, but it should be more than just a light scrape. All right? So now we've got Romberg and gait left and the fundoscopic exam. So you ready to demonstrate some walking? Yeah, I'll do it with you too. All right, so the Romberg exam is not a cerebellar test. It's frequently mistaken to be a cerebellar test, but the Romberg test is actually looking at position sense. So to do this, you ask the patient to stand there with their feet together. And if they're stable standing there with their feet together and their eyes open, the next thing is you have them close their eyes. It's always important to have your hands close to the patient. If they start to sway, all you have to do to get them stabilized and to stop swaying is to touch them. And they'll open their eyes and their balance will be back to normal. So your Romberg is normal. Next, we'll talk about gait. And this is the last part of the exam that I'll make Dr. Carr demonstrate for you. We're going to look at her normal gait. Will you just show us your normal walk? So she's got a normal base. Her feet are just inside of her shoulders. So if they were standing far apart, you think that she's got a sensory problem, she's got neuropathy, or that she has cerebellar dysfunction, and the wide base is something she's using to stabilize her. So her base is normal with her feet just inside her shoulders. Walk again for us. Her strides are normal, and you see that she's got a normal arm swing when she walks. What would you think is wrong with her if she wasn't swinging her arms? Any idea? Yeah, she's giving you some other clues. If there were
Shuffling
short
gait.
shuffling steps with no arm swings, that's Parkinson's
Yeah.
disease. You would be very concerned that someone has some form of Parkinsonism. The pattern of the gaits of the unchallenged gait is also important. We can pick up evidence of an old stroke. So I'll try to demonstrate what a hemiplegic gait or a spastic hemiplegic gait might look like. You might see one arm flexed, so the affected arm would be flexed, and the leg, they'll swing out. The leg is extended, and usually the foot is dorsiflexed and plantar flexed. So that's what a spastic hemiplegic gait would look like. It looks something like this. If someone has neuropathy, they can't feel the bottom of their feet, and it's very advanced. You want to mimic that? Can you do a steppage gait?
No, you did.
Okay, we'll try. So you can hear them walking down the hallway in the clinic. They will put their feet on the ground really hard every time they step. So their base will be wide, and every time they take a step, you'll be able to hear them actually walk down the hallway. That steppage gait can happen when someone has a foot drop due to a peroneal nerve injury, or if they have a pretty severe neuropathy and they've lost sensation. So there are a lot of things that you can tell from looking at just the unchallenged gait. And someone who appears to have a normal gait, you want to stress them a little bit. So the stress gaits that are standard are heel, toe, and tandem walking. So can you show us walking on your toes? So she's walking on her toes. Can you walk on your heels for us? And then take a few steps like you're walking on a tightrope. So these stress gaits can sometimes bring out subtle abnormalities that you don't see in the rest of the neuro exam. So particularly with tandem gait, you can identify patients who are at risk for falls from their underlying disease process. You may be able to bring out ataxia that you couldn't see in the rest of the neuro exam. So after all of that, the last thing that I usually do is I have patients come back into the room and I look at the back of their eyes with an ophthalmoscope. So to do this, the room has to be dark. We obviously can't make this room dark. Again, you want the patient to look in the distance. You want their pupils to be as big as they possibly can. And this one isn't even charged, so I'm not going to blind you. It's important as you're practicing this that you make sure that you use the right hand to avoid some awkward moments with the patient. So if you're looking in their left eye, you're going to use your left eye and left hand. So it would be like this. And I usually put my other hand on the patient's head so I know where I am in space. And then you move in closer until you're able to see the optic nerve.
Otherwise, you end up right here with them.
Otherwise, yeah. So if I was using my right hand and trying to look this way, I wind up right in Dr. Carr's face, which is, it's an awkward thing when it happens. So that's it. In the last 40 minutes, we've gone through a basic neuro exam. The real time to do this takes about 5 minutes. So once you've learned the exam techniques and gotten your order down, you can actually do this repeatedly on patients in the hospital and the clinic in just a few minutes. If there's one part of the neuro exam that I say is the most important and most helpful for people who aren't neurologists, it's testing reflexes. So some of the referrals that I've gotten for patients with multiple sclerosis or ALS have actually come from a classmate of mine who's an orthopedic surgeon. So someone was referred to him for a problem, and he checked reflexes and found hyperreflexia and clonus and correctly identified that there was a spinal cord lesion or there was a motor neuron process. So even if you're not interested in going into neurology, at least practice the reflex part of the exam.
Being able to do just even the most basic neuro exam will make you so much better just as a clinician in general. And it's funny because I used to be like, oh, reflexes, I can't do those. I'm never going to need to do reflexes. And here I am, a neurologist, doing reflexes every day. But it used to be just because I didn't know how to do them. And I was like, I don't know where you even find the spot. And it's not as hard as you think. You just have to practice.
All right, guys, thanks for your attention, and we look forward to seeing you again throughout this class and next year as you rotate as in threes.